My name is Janko Sacek, and this is a new episode of EuroHealth podcast. Our wonderful guest today is Dr. Charlotte Kock, a researcher from Ghent University who is conducting research into the accessibility of drug treatment for people with a migration background in Belgium and in Europe. Welcome, Doctor.
Thanks for inviting me. Hi.
I have a really long list of everything what you do, of all your background, but maybe you could tell us a few words about what you are actually doing right now, and what is it that you are researching into.
Okay, thank you. First of all, thanks for inviting me. I always like to talk about the topic of refugees and substance use. I've been conducting research concerning equitable substance use treatment for migrants and ethnic minorities at Ghent University during the past decade. And I focused these last couple of years more on the specific populations of refugees, because they appear to be specifically vulnerable concerning both substance use and the accessibility to substance use treatment in Europe. So these last years, and actually very recently, I conducted a research project as an external consultant together with the European Drug and Asylum Agency on the needs of professionals who work in the reception settings in Europe concerned with substance use in these reception settings. I think that's quite a summary of what I'm doing currently.
Well, in the last few years, we all, as European societies, have experienced quite a few crises, I would say, unprecedented in our lifetime. So the obvious question is, what was the impact of those crises on mental health and substance abuse?
Could you specify the types of crises?
Well, I think we can mention the war crisis causing obvious anxiety for the citizens of EU, as well as a huge influx. We in Czech Republic have experienced about 400,000 or 500,000 Ukrainian refugees in Czech Republic. And also, of course, COVID-19 with all those worries about whether we will live, whether we will die, and so on.
Of course, yes. I think the inflow of refugees in European countries is a logical result. It has always been of the international crises and political conflicts, also ecological conflicts that we've seen around the world. The inflow of, for instance, Afghan refugees, but also people from Palestine, Syria, and more recently of Ukraine, is reflecting in all European societies. So, for instance, in Belgium, where I'm stationed, we see that the inflow of these last four populations has grown a lot during the past decade. So the people who are in our reception facilities now, the refugee population, is mainly made up by these populations. That's what we see in all over Europe. Was that your question?
Yes. And do you think that there is a different situation for refugees, if we can, I would say, divide those two main waves of refugees? So, if we are talking about the refugees from Ukraine and refugees from Middle East, Afghanistan, Pakistan, etc.
The main difference I see is in the way we receive them, or how politics deal with these different types of populations. What we've seen in Belgium is that there has been quite a big response to the reception of Ukrainian refugees. We have rapidly built specific container villages, etc. We've even created at the European level a special status for these types of populations. So yes, definitely the reception of these types of refugees has been different. It's of course good that we have seen a rapid and positive response on receiving large numbers of these populations in European countries. But you can of course ask the question what this means for other types of refugees, such as people with Afghan, Palestinian, Syrian backgrounds, who may not always have received the same access to services, access to living conditions, etc. At least for Belgium, that is an important question to ask, because, of course, the way we receive refugees as societies has a direct impact on their integration possibilities, as well as on their mental health.
So I understand that groups in vulnerable positions, for example, refugees, facing distress in many aspects of their lives, face higher risk of developing mental health issues and substance abuse behavior. How does that influence specifically refugees in Belgium, and what could be done with that? What could be done specifically to address those issues and to help those people in need?
That's an important and very large question, of course. In the first place, I would like to make a difference between the types of substance use that exist, of course. There's recreational use. There's substance use that people use as self-medication also. And then there's what some might call substance use disorders, abuse, misuse, etc. So it's important to see that difference, of course. Now, if we look at a population that would describe themselves as problem substance users, or who would fall into the DSM categories of having substance use-related disorders, there are, of course, many overlaps in the risk factors that we see in the general population, so people without migration backgrounds and people who do have a migration and or a refugee background. We know, for instance, in the general population that PTSD or PTSS, as related to trauma, is related to a higher risk to substance use. And of course, if you look at the refugee population, many studies have indicated that the prevalence of PTSD or trauma-related disorders is larger among refugee populations. So in theory, there is indeed a larger risk for substance use and problem substance use in these populations. So that's one thing. The other thing is, if we look at the general population of people who deal with substance use-related problems, we see that there are many vulnerabilities related to, for instance, housing, but also education, employment, etc. Of course, you can always ask the question, what is the direction? Was substance use a result of having these problems, or is it the other way around? It always goes a little bit in two directions. But if we look at the refugee populations in Europe, we see that they often have less access to employment, have less access to education, have worse housing conditions. So, of course, this can make them even more vulnerable to mental health related issues, including substance use. And then lastly, this is, of course, also related to our reception policies in European countries. Our reception policies have a direct effect on the mental health of these populations. If you are housed in a reception center or a reception camp, for instance, in Greece, if you have to stay there for several months or even years, this, of course, impacts your mental health. And dependent on your own coping mechanisms, this might result in using substances.
Well, the obvious question is, could you specify what are the most misused substances in the groups that we are talking about? I guess that we could maybe assign some more typical substances to some of those groups, or is it just the same for all of them?
Yes, that's an interesting question with a complex answer, of course, again.
Yeah, of course.
First of all, no, it is not possible to assign a specific or typical substance to specific populations. As a researcher, I also try to avoid that, or I try to be very careful with that, because it can add to extra stigma of already stigmatized populations. In the second place, I should say it is very hard to really measure the prevalence of substance use or substance misuse in refugee populations, because, of course, they are hard to reach. If you look at the European countries, almost all the European countries, for instance, have a national health survey where there are questions concerning basic substance use, alcohol use, cannabis use. But if we look at these health surveys across Europe, we see that they have representative samples for the country populations, but not for people with a migration background. So prevalence at population level is really difficult to estimate, and we have little of those studies. We do have some studies in mostly northern European countries, such as Sweden, Denmark, etc., where we can find some indications of prevalence. That's for one thing. What the little studies that exist seem to point out is that in recently arrived migrants, substance use appears to be mainly related to substance use habits in the home country, of course, compared to the receiving country general population. The prevalence appears to be lower, but the longer the stay in the receiving country, the more the substance use converges to the substance use culture of the receiving country. That's the type of conclusion we can draw. Now, in the study that we've done, so the European Asylum Agency and the European Drug Agency study that we conducted recently, we asked professionals in the reception setting, which type of substance use do you observe? And of course, it should be said that this is only the observed use. This is not a prevalence study. But what a professional in these reception settings see is actually, in the first place, comparable to what we see in the general populations in Europe. They observe mainly alcohol, tobacco, and cannabis use. Now, a nuance to make here is that in many reception settings in Europe, we also see the rise of the use of medication, use and misuse of several types of medication. Mostly what we see at this point, what is becoming problematic or what we should study more is the use of pregabalin, or the Pfizer medicine Lyrica, which is actually a medication that is used for epilepsy, to control seizures, to treat nerve pains, fibromyalgia, etc. It basically blocks pain. And Lyrica, or pregabalin, is used by people who is often used in combination with heroin, for instance, but also other opioid-based medication. It can be prescribed for the first time upon reception in the EU, for instance, in the Greek islands. But it is also described widely in Belgium, for instance, both to the general population as well as to refugees. And the use in high doses of this medication is becoming a worry in many European countries because it is used exactly in high doses. But it is used often as a type of self-medication. People who live in the streets, who, for instance, do not have access to the reception setting, simply because there is no place for them, because there is a large number of refugees coming in, and because political decisions are being made that they do not have place in the reception setting. So they land up in the streets. And honestly, if you and me would land up in the streets, I think it wouldn't take us a long time in winter times to go in search of medications that would help us not to have colds or not to feel our mental or physical pains. And then pregabalin is an easy solution for many of these people. So pregabalin is one of the medications that is becoming a worry, but also other opioid-based medication, such as tramadol, and benzodiazepines are being observed as used in by these populations. Yeah.
Do you think that this phenomenon in general is getting enough attention on the European level?
I think the attention is definitely rising these last 5 years, let's say. It is really growing, and it is really nice to see this. When I started in this research domain, there was much less attention. The focus was also more on the type of populations that were the result of labor migrations, so second, third generation migration backgrounds. And nowadays, the focus on new migrants, refugees is definitely rising. We see that in the efforts made by the European Drug Agency in collaboration with the European Asylum Agency. The work that we've done, or in which I was implied as an external consultant during these last years, is actually seminal. A collaboration between the Drug and the Asylum Agency. It was one of the first efforts in its kind, and I think it's a very important evolution. At the international level, the interest has been there already for some longer time. We see that UNODC, for instance, has already formulated many concrete recommendations for countries concerning mental health and refugees, concerning substance use and refugees, and they are also supporting specific intervention trials, for instance, in humanitarian settings across the world. So, to answer your question, is there sufficient attention? I'm happy to see that the attention is rising, but we should keep the efforts going. And I think, of course, that there should be more emphasis on these types of problems without only problematizing the population itself, refugees, because, again, this can create extra stigma for these populations, but also critically look at the results of our reception policies, our restrictive reception policies, and the impact, the important negative impact this has on the mental health and substance use in these populations.
So we mentioned the European level, and what is actually the recipe that should be implemented on the national level, and what should do, let's say, regional or local authorities? I believe it should be tackled by all those levels. It's not something that you could really solve purely on European level.
If I would have the recipe, I would be out of work, of course.
Okay.
There's different answers to that question. First of all, it appears that if you look at the domain of substance use, it's the scientific domain of substance use, treatment, etc. It has always been very separate from the domain of migration studies, etc. So there needs to be an encounter of those two domains to share expertise there. What does that mean concretely on the national level, on the ground? First of all, there is a difference if we look at intervention studies between the prevention of substance use, where we try to delay substance use in young people, for instance. Then there is the area of early intervention. Once people already use substances, we try to intervene early to try to limit substance use. Then there's the treatment of substance use. If people really recognize they have a problem with substance use, how do we treat them? And then there is the fourth area of harm reduction, which can be done, for instance, if people use heroin, we can use substitution medication such as methadone to reduce the harms such as infectious diseases, for instance. So these are four very different domains for different types of populations. And the knowledge of these four different domains needs to permeate the reception settings. What do I mean concretely by that? Is that if we look at unaccompanied minors, for instance, say a boy with an Afghan background arrives at 14 years old in a reception center in Belgium, we want to make sure that this boy who has not been in contact with substances yet has the tools, has the personal tools to deal with substance use once he is confronted with that. We want to help him strengthen his coping mechanisms, for instance, how to deal with peer pressures, but also how to deal with hardship, the hardship that he encounters in his current situation or that he may encounter based on pre-migration experiences, such as trauma. So we need to focus on that in this population. Now, if we have, for instance, a girl who comes from Palestine at 22 years old, and she is already using some type of opioid-based medication. She was already using that when she was living in Palestine. This is, of course, a fictitious example. We want to deal with that in a different way. We want to do we want to use early intervention methods, maybe some interventions from harm reduction too. But what I want to say with these two examples is these are two different populations. We cannot go with our material for harm reduction and early intervention to this 14-year-old Afghan boy, because adolescents who are, for instance, very curious, if they are confronted with information about substances, about the risks of substances, it could in fact enforce the curiousness to substances. So it can have a detrimental negative effect. So this type of knowledge really needs to permeate the reception setting, so we can have targeted interventions for these different types of populations. And then on the other hand, to go back to the treatment level, if people realize they have a problem and they want to deal with it, they are motivated to do so. In the first place, of course, they need to be supported in the reception setting. Once they have the motivation to work with their problems, they need to be motivated by the social workers in the reception setting to stick to that idea, or need to be supported in this motivation. But then there's the access to treatment, of course, which is often limited for these types of populations. It varies across European countries, and mainly in many European countries, refugees have the right to basic medical care. But then, of course, it depends what we mean with this basic necessary medical care. And that varies often across countries, and oftentimes it's decided by general practitioners, for instance, or by the reception authorities, what is urgent medical care and what is not. So the question is substance use treatment going to a psychiatric hospital, for instance, is that urgent medical care? And do refugees have access to these services that are there for the general population? And that appears to be a very large problem. First of all, for instance, psychiatric hospitals or psychiatric sections of general hospitals are already limited in their accessibility to the general population. In Belgium, for instance, we have waiting lists for such services. In general hospitals, less than in psychiatric hospitals, but in psychiatric hospitals, the problem is large. So these are residential settings that are already limited in their accessibility to the general population. And then comes the language problem. Language is often used as an exclusion criteria for these types of settings. Next to that, if these types of settings believe that there is no health insurance, or if there is de facto no health insurance, this can also be a reason to exclude these populations from these types of settings. So that's a problem that we question, that we need to ask how we will answer it in the settings themselves. How do we deal with the language problem? For instance, in Europe, we see that many substance use treatment services are focused on language-based therapy, but also group therapies where language plays a large role. Then we need to ask the question, is this the method that we keep as a dominant method? Is that sufficient? Or should we think about residential settings that have more varied methods that aren't only language-based? But we also need to ask the question at the governmental level, to what degree do we offer language support? Should we expand language support to these types of services? And of course, you can hear in the way I'm explaining it that I'm strongly convinced that we need more funds and more training of professionals in these settings to work with language problems. Well, I guess that's most important, I think, to do on the ground for me.
You mentioned different situation in various EU countries. Do you think, is there any role model, some country that we could really take the best practice from?
The refugee flow in different European countries is very different. Some European countries are mainly transit countries, for instance. So this means that people, refugees, or applicants of international protection will not apply for international protection in these countries. This means that if these people deal with substance use that they take from countries, or that started in countries they had passed previously, or that started in their home country, these transit countries deal with these problems with a very different way. In a very different way, I mean. You cannot not do long-term treatment for people who are only thinking about passing your country. So these types of countries should, for instance, exchange practices among them. Then there's countries who are more seen as countries that people where people do want to reside in the long run, and this, of course, have implications on the way you can deal with substance use-related problems. So no, I don't think there is one prototype of European country. On the contrary, we should share practices across countries. We should first of all share what we see of concerning substance use trends. For instance, the pregabalin use is something we see across European countries in both transit and arrival countries. We should share these trends to create shared responses. That's one thing. On the other hand, there are also some countries who deal with substance use in a more holistic manner, I think. And then I do think, for instance, about Sweden, a country that hosts a large number of applicants of international protection, but also recognized refugees, where there are currently projects ongoing where we focus more on general mental health for these populations. Evidence-based interventions that support integration and mental health of these populations. And these are the types of interventions that are actually needed in many more European countries. So I do think that we should share these types of practices across European countries.
Let me ask you, if you were given absolute political power in EU for one day, what would be the thing that you might actually want to change, of course, in your field of scientific interest?
You just gave me a very big mandate. Thanks for that. In the first place, and that's of course not my domain, but we have to look at how we receive refugees.
Okay.
If we look at Belgium, the asylum procedure can take a very, very long time. Some people reside in reception centers for over 2 years. Mm-hmm. These people are staying there without any perspective, also with limited integration chances. I mean, if you are not sure yet if you can stay in that country, you cannot really think about the future. It causes huge mental health-related problems. And again, if you and me would be in this situation for 2 years in a reception setting, I think self-medication would easily become an option. So we need to think about how we receive refugees. We need to look at real integration. And this will be positive for the mental health of these populations. That's one thing. Look at the reception policies we have in the countries. A second thing is the access to mental health settings and health settings. The access needs to be there for everyone. And in many European countries, we have that in theory, but not in practice. And we really need to look at that critically to make sure that people who are residing here, who are applying for international protection, that they have sufficient good quality access to treatment. And then access is, of course, only one thing. If we talk about equitable healthcare, we are talking about equitable access, for one, but we are also talking about equitable quality of care and about equitable outcomes of care. So access is the first thing, but quality and outcomes are equally important. And maybe I should repeat, of course, what we mean by equitable healthcare services. Equitable services, or offering equitable services, means that people who have similar needs, health needs, get similar care, but that people who have different needs also get adapted care. Only if we have these two types of services, so both general services as well as indicated or adapted types of services, we can talk about equitable care, and we really need to look at that. And then in the substance use domain specifically, we need to insert the expertise of the substance use treatment, prevention, early intervention, and harm reduction domain. We need to insert that in the reception context. In many reception settings in Europe, there's a belief that if there are large substance use related problems, we need to redirect the populations to these types of services in the country. But I don't fully agree with that. It's true that you need to redirect populations to the services that exist, but we need to do a lot more in the reception setting itself. We need to look at the environment of the reception setting, the expertise that is in the reception setting. And of course, I want to stress that what we see in many European countries is that the efforts of professionals in these settings are huge, that they are trying with all the efforts they can, but they also need sufficient funding, of course. They need sufficient training, they need sufficient support to work with people to enhance their mental health and subsequently also substance use.
Oh, great and exhaustive answer. Thank you so much for your time and contribution.
Thank you very much for inviting me again. I really hope we can move forward in this domain in the years to come.